Thanks a lot for inviting me here. Basically, I will start from the time when we started putting the IOL. It was Harold Ridley who first implanted the IOL, and then from then onwards, a lot of advancements have been done, and a lot of advancement in terms of material design and IOL delivery. And the basic idea was to have a persistent 6 by 6 vision, or the best vision that we can have. And we achieved also over the years. But then there were issues regarding patient wanting to be spectacle free, and then came the concept of these multifocal lenses. And then multifocal lenses, they came up, there are a lot of issues, a lot of problems. But then a current generation multifocal lenses came up, there were a lot of advancements. And then there was a reasonably good vision for distance and near with even these multifocals or bifocal lenses, to be more precise. However, there were a lot of issues in terms of intermediate vision, because most of us now are into laptops and computers wherein intermediate vision is an issue, which is 60 to 80 centimeter. And from then, these extended range of vision came into being, and then people started thinking of intermediate vision as well, because of the computer distance and all that. And the basic idea is to the basic mechanism by which it works is that it extends the depth of focus, and it elongates the focal area instead of having multiple foci of like a bifocal lens, one foci for distance and one for near. And so this is one Supra 4 Infocus lens, which is an extended range of vision lens in which the depth of focus is elongated. It's not the single point. It has a specific design. Obviously, you all must have discussed about it. I will be very short in this. It has a specific design, a central zone of 1.2 millimeter diameter, which is primarily for near and intermediate vision with ads of 3.5. And then from 1.21 onwards, it is basically for the different distance and different range of distance. And basically it works on transmission of light. As the pupil becomes bigger, the transmission of light is more for distance, and as the pupil becomes small, the transmission of light is more for near. And it has an elongated defocus curve, and that's why it gives a range of vision. And so we just wanted to test this hypothesis, test this claim actually, that whether it does have an extended depth of focus, whether it does have a good near and distance vision or not. And we did a study in which we included 55 patients. The basic idea was to do a study of 50 patients, 100 eyes, but we just added 5 more. So it was 55 patients with bilateral implantation of Supra 4 Infocus. And we had thought of, we thought that if 5 will be, 5 patients will not follow up, so we'll have at least 50 patients. So 3 patients did not follow up properly actually, and so out of which one patient who was quite old had some cardiac arrest and died. So we had 52 patients with 104 eyes with complete data, wherein the follow-up period was, we had followed up for 5 to 6 months, but we evaluated data up to 3 months only, because that was good enough. And in all the patients, we had done a temporal clear corneal incision of 2.2 millimeter for phacoemulsification, and subsequently for implantation of the IOL, we enlarged it to 2.8. Now, this is how we did. This is temporal clear corneal incision, and capsular access being performed, hydro procedure, and then phacoemulsification and completed, and cortical aspiration done. And once there was complete cortical aspiration, the eye was set for IOL implantation. Now at this stage, since we performed phacoemulsification by 2.2 millimeter incision, I enlarged the incision by a 2.8 millimeter blade to make it 2.8, so that the tip of the cartridge goes inside the anterior chamber, and then the IOL was implanted in the bag. And what I felt that it was very easy to implant the IOL. It goes well, the decent cartridge, and the lens centers well in position. and once it was done, viscoelastic was aspirated out, and then the wound was hydrated, and we just checked the centration of the IOL. It centered well, and that was it. Now, we evaluated, if the distance, post-operatively, we evaluated patients on day 1, 1 week, 1 month, and 3 months. And we had the distance chart by ETDRS, the near chart, the Roman test type near vision chart, and the intermediate chart is the Sloan-Letter intermediate distance chart. This is, okay, they have to, do you have any other speaker, or we'll just?
It's just you, it's just you, Rajesh.
Okay, okay. So, we had the intermediate vision was taken by Sloan-Letter intermediate distance chart, and this is something which is meant specifically for intermediate vision, and very few studies have been done using this. So I'm extremely thankful to Appasamy and Shiva and Mr. Ramurthy for providing this Sloan-Letter intermediate distance chart, and also the Mars contrast chart and the pupilometer to measure the pupil size, so as to know exactly whether the patient has any issues with a scotopic pupil size or the mesopic pupil size. And then stereo acuity was also evaluated, a refraction, defocus curve plot, and then the patient, these are the follow-up periods. So this is how we did the pupillometry. This is the pupilometer. This is how it was done. So just
what are you evaluating here, Rajesh? Explain this to us.
Yeah, it is actually, I could have shown a sorry, the image of the pupilometer I'm not showing, but basically the idea is to it's hung there. So basically the idea is to measure the pupil size with light and with dim light. So mesopic pupil size and the photopic pupil size. And I will tell you later, based on that we did the aberration study. Okay, and the basic idea was this, that whether this patient will have an aberration, as you were mentioning just now, nighttime vision and nighttime aberrations, etc. So we just wanted to know exactly whether what is the pupil size in the dim light with the pupilometer in this patient, and what is his problem, visual acuity and all that. So we just wanted to know whether he will have any problem in dim illumination, whether he will have problem in driving or not. Now, we had, this is the age and gender, we had 27 males and 25 females out of 52, and the post-op visual acuity, you can see at 3 months, the logMAR visual acuity is, this is the uncorrected visual acuity of 0.11, which is, and best corrected is 0.02. So it's 0.1 means it is 6/6 vision. So this is close to 6/6 vision as far as distance vision is concerned. As far as the intermediate vision is concerned, it is again quite close to what we should have at 66 centimeter. It is, so in a way, on an average, you can say it was between N6 to N8 on an average. Some patients had N8 and majority of patients had N6 vision. Actually, this evaluation has been done, analysis has been done just 4 or 5 days back only, so I am not able to present the whole data, wherein I have, you know, exact number of patients with N6 vision, with intermediate vision, all that, but this is the mean value that I am presenting. Then as far as near vision is concerned, here you can see at 3 months time, 103 eyes out of 104 had N6 vision. Only one patient, one individual had N8, so that was remarkable actually. And now here at this point of time only, I would like to tell you that you know, when we started doing, in the first 1 or 2 cases, we took the first myopic on IOL master as the target refraction. Say on IOL master, if I was getting minus 0.25, so I was taking that value as the IOL power. on one or two first, just one or two cases initially on day one, I felt there was some refractive error, and the patient had N8 and 6/9 vision. So and then on when we did the refraction, it was coming out to be 0.5, and here I would just like to mention, see, this is the corrected vision actually. So what we did was we corrected the distance by minus 0.5. Then we found out that his vision was 6.6 and he was getting corrected to N6.
By correcting only the distance.
Only the distance. So then, based on that finding, we went to one power ahead. Like we went to the target refraction of minus 0.5. Anything around minus 0.5, minus 0.45 to minus 0.7 was the range. And yeah, target refraction on IOL master.
Is this with the SRKT or a Barrett? Which is the formula you used?
We used the SRKT.
Okay, thank you. 118.8 is the optical A constant.
Yeah, A constant is 118.8. So, so based on that, we found out that the results were outstanding actually. And this is not something because I am in an Appasamy session, I am telling this thing. After that, I encouraged many of the staff patients also to undergo this, get this IOL implanted, and they are very happy. So I am personally very happy with this. The basic key here is that the target refraction should be around minus 0.5 to get the best outcome. Don't go for emmetropic, don't go for the first myopic minus 0.1 or minus 0.2. That is the key. And we had a fantastic result. As far as contrast sensitivity is concerned, it was again very good. It was, you know, the normal log value is more than 1.48. So we had a mean value of 1.45, 1.46. That was quite good, considering it was an IOL inside the eye. Then distance stereo acuity was also within, very close to the normal. And this is what was calculated by pupillometry. The mean mesopic pupil size was 4.12 and 4.15. So on an average, you can say 4.15 in these patients. Now, once again, I would say the mesopic pupil size of 4.15 is a very good pupil size. So the patient selection is also very important. If you have a mesopic pupil size of, some people do have mesopic pupil size of 6.5. 7. I have seen such patients, and they have been referred to me that what to do, whether we should do LASIK or whether we should do any procedure. Such patients are not good for these lenses. So, I mean, you can have good outcome if you do a good case selection also. That is also important. As far as the higher order aberration is concerned, the mean coma was 0.35, which was again a good outcome as far as the higher order aberration is concerned. So, I would conclude here by saying that, you know, we still have to analyze some more data actually. And we also analyzed this all coma and trefoil. This was calculated on eye trace, and we have a whole set of data. Unfortunately, the analysis is not complete. Maybe sometimes later I'll be having the whole thing analyzed. But whatever I could figure out, I could see that the aberrations with 5 millimeter pupil and aberrations with 3 millimeter pupil were mostly comparable in this. At 4.5 and 3 millimeter were mostly comparable with this IOL. So that was a good thing that, you know, that was quite encouraging thing that we found out in this, with this IOL. So this, the set of patients that we included had good distance, intermediate and near acuity. They had good contrast sensitivity, good stereo acuity, and no significant photic phenomenon, basically because of the design that dips inside and the rays are, so you have limited scattering. And the aberrations were acceptable with 3 millimeter as well as 5 millimeter pupil size. Mildly better aberration control with 3 millimeter, but with 5 millimeter also there were few patients only who had a significant aberration, and the patient satisfaction was really good. However, we all know that with all these lenses we have to do good patient counseling, but with all these we found out that you know, if we ask the patient whether you will ask your relative to undergo, to get this IOL, almost every patient told that yes, we are happy and we will ask our relatives to have this IOL. So particularly I am myself very pleased with the results of the IOL that we implanted.
All right.
Thank you.
Thank you.